Welcome to our next video. Today we're going to look at the systematic structured assessment of orthopaedic patients. It can be quite daunting managing these patients who may have more than one type of injury. And I remember as a medical student when I was asked how to manage these patients, a structure like this would have been extremely useful. So let's have a look at this. It focuses on the 4 R's. These are resuscitation, reduction, retention of the reduction, and finally, rehabilitation. Let's take a look at each of these in a little bit more detail. So, firstly, resuscitation. It's important to note that any patient we see in the emergency department we assess to make sure they have no life-threatening injuries in the first instance. This may be very obvious to do, such in those patients who have high energy trauma, such as road traffic accidents. Or it may be less obvious to do in those patients with low energy injuries, such as the elderly lady who's fallen over from standing in the back garden. It's important, however, to always ensure we do this resuscitation assessment, as even those patients with low energy injuries, especially in the elderly population, may have other pathologies, such as bleeds in their head. It also ensures that we make sure we don't miss any other injuries before focusing on the obvious presenting plane of the patient. So, resuscitation is very protocolized and consists of the Advanced Trauma Life Support Guidelines. This is an A to E assessment, including the cervical spine in the airway, and ensures that we do not miss any injuries. So, we look at the airway first, the breathing, circulation, disability, and exposure/environment. Once we've done this and ruled out any other more serious or life-threatening injuries, we can then focus on the patient's presenting complaint. So let's take that example of our patient with the deformed and painful wrist after having a fall in her back garden. Now, the next step in our pathway focuses on reduction. In orthopaedics, reduction refers to returning the bones to their normal alignment. This may already be the case when you see the patient and obtain the X-ray, such as those fractures that are undisplaced. Or it may be very obvious that the patient has a fracture and it's with the deformity and requires reduction. Reduction can be done in numerous environments. It can be in the emergency department, in the operating theatre, or in some special cases, it can be done before the patient arrives at the hospital, such as those reductions that are time critical in special cases, such as knee dislocations. But most reductions are done in either the emergency department or the operating theatre. So taking our patient with her deformed and painful wrist, let's say that she has a wrist fracture. Now, wrist fractures, for example, can be manipulated in the emergency department with good pain relief and sometimes sedation. If we're able to return the bones to a good alignment, then it may not be necessary to take the patient for an operation. If, however, we are unable to do that, then it may be required for us to take the patient for an operation so that we can perform an open reduction, where we see the bones and visualize them directly and reduce them with implements. Now, assuming we've obtained our reduction, the next question is how to hold that reduction where we've obtained it. Some fractures are very stable and don't require much support to be held in a reduced position. Other fractures are much less stable and after reduction may slip back to their old position of deformity or redisplace. So the question is, how do we hold that reduction? Well, in the emergency department, if we performed a manipulation to try and reduce the fracture, such as with our wrist fracture, we can try non-operative methods of holding the reduction. These include casts, and splints. Sometimes these work, and obtaining an X-ray after putting the patient in a cast following manipulation will show that the wrist is in a very good condition and position, and we may not require an operation. If, however, we can't obtain a good reduction, or once we've obtained a good reduction, we can't hold that reduction and the fracture slips back to its previous position, then we need to perform an internal fixation. So this goes along with the open reduction. So once we have reduced the bones, having directly visualized them, we can use a number of orthopedic implants to try and hold that reduction, hold the bones in the correct position for them to heal. These include screws, plates, nails, and so on. Now, once we've held that reduction in the correct position, whether that's with non-operative means such as a cast or a splint, or whether with operative means such as an open reduction and internal fixation, the fracture will then heal over the next 6 to 12 weeks or so, or even longer in some cases. And this depends on the type of patient you have, whether they're elderly, whether they're young, whether they smoke or not, and sometimes even the age of the patient. We then want to make sure that we restore the patient to their prior level or pre-injury level of functioning. For the lower limb, this will usually mean getting the patient back to weight bearing, as most patients were weight bearing before they had a lower limb fracture. For the upper limb, this will consist of getting the patient a good range of motion to be able to manipulate objects with their hands as they were doing before their injury. And this usually consists of physiotherapy. We can make physio referrals and they will then follow them up and give them useful exercises to ensure that they build up their muscle strength and function to their pre-injury level of functioning. So that was a quick whistle-stop tour through our 4 R's and how useful they are in giving us a structure in managing orthopedic patients. Looking at them one by one again, we start off with the resuscitation to ensure that we do not miss any life-threatening injuries. Having moved on for that and ensuring that the patient has an isolated injury or that we've treated more serious injuries, we then look at how best to reduce the injury or return it to its original alignment, assuming the patient has a fracture. This can be done in or outside the operating theatre, depending on the type of fracture and also the patient in some cases. It also depends on the resources we have and also the age of the patient in some cases, as children do not tolerate manipulations in the emergency department and therefore may require a general anaesthetic. Once we've done that, we want to make sure that we hold that reduction in the correct position, and this can be done either with casts or splints, non-operatively, or with and following an operation, having directly reduced the fracture under direct vision, we can then hold it there with certain implements and orthopedic implants. And once we've done that and we've followed the patient up and the fracture's healed we've given the fracture a reasonable amount of time to heal, we can then get the patient's range of motion increased and get them weight bearing and return them to their previous level of functioning. I hope you found that useful. If you have any more ideas or suggestions for topics you'd like me to cover, please feel free to comment below or on my Instagram. I hope to see you on the next video. Thank you very much.